want to introduce Kate Kralich, who is the Director of Operations at Care Navigators. She's going to explain the CE process.
Hi, everybody. Thanks for joining us today. Everybody will get an email after the presentation. It will include an evaluation form on the presentation. Once that form has been completed, we will get an email right directly to myself, and the certifications will be emailed, the certificate right to your email after your evaluation form.
Thank you, Kate.
You're welcome.
Anything else? That's good.
Yeah.
All right, great. Now I'm going to introduce a few more people that are responsible for this program. First of all, I'm going to introduce the, Belmont Village communities representatives that we have from the 5 Chicago Belmont villages. So as I mentioned, I'm Erin. I'm with Geneva Road, Carroll Stream location. I'm going to have the following people to say hi and wave their hand, wave when I say their names. So Janine Paterno is with our Glenview location. I also want to introduce Shalina Thomas, who is with our Oak Park location. I want to introduce Jody Weinberg, who's with our Buffalo Grove location. And finally, I want to introduce Lauren Hollish, who's with our Lincoln Park program. So a lot of you may know them, and if you don't, we hope you get to meet us very, very soon. So I also want to introduce our other healthcare sponsors, Leonard Sanchez from Bright Star Senior Care, DuPage County. I'd also like to introduce Joe Monforti from Suncrest Hospice Care. And I'd like to introduce Brett Shepard from CareLink Home Health. So all these people that you're meeting are partially in some way responsible for this program. So I wanted to thank all of them for their sponsorship and help with this program. So with that, each of us are going to share a very brief slide about what our companies do. And then I'm going to hand the program over to our speaker, Jean Llamas. So I'm going to start with a quick slide on Belmont. Can everybody see this? Yes. Okay. Jody, can you see this? Give me a thumbs up. Thank you. All right. So Belmont Village is in Chicago area is assisted living as well as memory care. And many of our locations have been around for up to 20 years. Some of them are newer, like our Lincoln Park location is a little bit newer. And we have 31 Belmont villages throughout the country. Some of them have independent living, but the Chicago ones do not. There are 31 throughout the country, and we all have assisted living. And under the assisted living, we have respite stays that are available. Glenview and Carroll Stream or Geneva Road do have sheltered license, which means we can do up to a 2-person assist, which is rare with a lot of assisted living communities. We also have quite a few memory care apartments at each of our communities, and we have varying levels of memory care. We're very well known for an area called Circle of Friends, which is a non-secured area of memory care for folks with mild to moderate dementia or mild cognitive impairment. So a lot of families like that because their loved one has mild impairment and does not need to be in a secured memory care area. We also have a secured memory care area for moderate to late stage dementia called the neighborhood. And we would need to do an assessment, of course, to determine where that person would best be suited. So that's just a little information on Belmont Village, and please reach out to any of us if you have any questions. With that, I'd like to pass it over to Leonard so he can tell you a little bit about Bright Star.
All right, hopefully everyone can hear me and see my screen. Just want to thank everyone for joining us today and this afternoon. Thank you, Belmont Village, for the opportunity to co-sponsor with my esteemed colleagues for the CE event. Bright Star Care, as you may or may not know, is a nationwide provider of care in the home, whether it be from caregiver basic services to all the way to very highly skilled infusion or antibiotic infusion, wound care, wound vac. So we do provide that on a private pay basis. A number of us are working already with Belmont Village, as our office in Wheat is with the Carroll Stream location. There are 17 offices in the Chicagoland area for Bright Star Care in Northwest Indiana. And we're ready here to serve you guys and your staff, your patients, your clients, anytime, anywhere. We're accessible 24/7, just like the rest of you are. And we are focused on being not only just Joint Commission accredited, but demonstrating that to the nth degree to each of you. So hopefully you'll get a chance to get to know us as we have with you. So thank you very much for the opportunity to join you.
Thank you, Leonard. All right, let's pass it over to Brett at CareLink Home Health.
Great, thanks, Aaron. Hopefully everybody can see my screen. I apologize, little camera difficulties this morning. Really excited for such a wonderful turnout here and working so closely with Belmont Village here in Carroll Stream. We got a great group of providers that work tirelessly to put this on, but this can only be successful because of the audience that we have out there. CareLink Home Health, you know, we want to link your patients to exceptional care at home. We cover 7 counties here in the Chicagoland area. We are ACHC accredited, Medicare certified and licensed here in the state of Illinois to provide nursing, your full range of therapy services, social work, and home health aides in the comfort of your patients' homes. So if there are ever any questions or concerns, please reach out to us and we are here to assist. And I'll pass this back to Aaron.
Thank you, Brett. Okay, and then we're going to pass it over to Joe Monforti with Suncrest Hospice Care.
I just wanted to let everyone know I'm with Suncrest Hospice and I am the hospice community liaison. We are here in the Chicagoland area. We've been here for about 4 years now. We are currently in 9 different states across the country. Chicago is one of our newer locations. We're not the largest hospice provider, but we're one of the best. And some of the things that differentiate us from some of the other hospice providers out there is that our standard of care for our patients is we try to have 7 touches in 7 days. Our CNAs will visit 5 days a week, and it provides the care that our family and patients need. We're available 24/7, and any of the needs that arise, we are available there to come out in person or help the providers, the primary caregivers walk through whatever crisis the patients are having. We are covered by Medicare, and we work currently with a lot of the communities in the Chicagoland area, Belmont being one of them. And I just want to say thank you so much for having us be a part of this, this great opportunity and this great CEU.
All right, thank you, Joe. All right, let's get started with the program now. And thank you to all of you for taking the time to tell us a little bit about your business. I'd like to introduce Jean Llamas, who's our speaker today with Care Navigators. She has such an impressive resume. It would take me 20 minutes to read everything that she has done over her career and all of her accreditations. But Jean is the president and owner of Care Navigators and Care Guardians. Jean has 24 years of experience as a registered nurse in a hospital setting, skilled home care, evaluation and setup of durable medical equipment, private duty nursing, utilization management, outpatient and inpatient care management, diabetic education, and insurance case management. She received her Master's of Nursing with a focus in business from Benedictine University and a bachelor's degree in nursing from Northern Illinois University. And she has about 10 accreditations after her name. I'm not going to go through all those, but she is just excellent in every way.
So what are our objectives today? We're going to talk about dementia. We're going to talk about MCI, mild cognitive impairment versus dementia. We're going to talk about the family's denial with dementia. We're also going to do we usually do an interactive discussion, but I will put the interactive presentation PowerPoint slides up there and you guys can chat in some information. I'll tell you when we get ready for that. So just a tiny bit about Care Navigators. We are a perfect care management company to assist you with your very difficult families. Any of your families that are overwhelmed with dementia, it takes lots of conversations with them to get them on board. So we can assist with bringing in providers like all the wonderful sponsors that we have on here, helping move them to a community, helping with hoarding situations. We do guardianship, power of attorney services, and counseling. We also just started doing neuropsych evaluations and medical visits. So that's enough about us. So you could go ahead and change that slide. Are you guys able to hear me okay if somebody can respond? Leonard, are you able to hear okay?
We can hear you just fine, Jean.
Okay, great. Somebody just let me know if there's an issue. Okay. So we went over the objectives. You can go to the next slide. Understanding dementia. So what is dementia? This is a general term that means that there's memory issues. There's some language issues. There may be some visual perception issues. There's also problem-solving issues. So a lot of people tell me, well, I need to know what type of dementia my family member has. Dementia is an umbrella, as you see in the picture, for lots of different types of dementia underneath of that. So Lewy body dementia, Alzheimer's, which is one of the most common. So there's many different types, and it's fine. And you really cannot find out if someone has Alzheimer's type until you do an autopsy. And there's some other newer tests, but really that is not something easy to find out. So it's just better to let your families know dementia is dementia. But there are some significant things to know about each of those types, which we're not going to go into today. It is different than the normal aging process. So we will be talking about that. There's treatment to reverse this disease. Okay, so you can go to the next slide. So some statistics. I'm not going to go over all these because I really want to get into how do you help your families dealing with dementia. So I'm going to read off a few of these. The lifetime cost of care is over $341,000. That is a lot of money. Most clients do not purchase long-term care insurance, but all of us that are younger on this call may consider that does cover at various communities and for home care and other services. So also in 2018, there was over $277 billion that was spent on the disease. And they believe that that's just going to continue. They're saying by 2050, there'll be $277 billion spent. And there is somebody who's diagnosed every 66 seconds. It is the 6th leading cause of death. But when you see a death certificate, usually for clients, this is not always going to be listed on the death certificate. They may have had a fall and they have a broken hip. So that may be the complications from that's listed, or pneumonia, or dysphagia, difficulty swallowing. You could go to the next slide. So this is the difference between abnormal and normal aging. So abnormal is the side where we may be considering dementia. And one of the things that we always want to rule out when we're thinking about dementia for a client is rule out electrolyte imbalances and rule out anxiety or other different issues that are related to allergy, et cetera. But when you do see a client that's starting to exhibit abnormal signs on the left-hand side, which is poor judgment and decision-making, they can't create a budget. They have a really difficult time with finances. They're losing track of the date or what season it is. They're having difficulty with conversation. Word retrieval is a huge thing. That starts at age 40, just so you guys know, a little bit of word retrieval issues. So that's normal, but abnormal is somebody not even understanding the word for like umbrella or watch or TV. They misplace things. That's not all of us that misplace our keys here and there. They're doing this frequently. And one of the biggest signs I see is paperwork everywhere. So if you're going in there in whatever fashion you are, whatever discipline, whether it's a care manager, skilled home care, et cetera, you're going to see birth certificates and paperwork all over the house, especially in the kitchen. So normal things are, we all make bad decisions. We might miss a monthly payment on our bills. All of us forget what day it is. I'm terrible with the actual date. You might forget a word to use. Like I said, that starts at age 40. You might lose things time to time. You can go to the next slide. So one of the issues that I see, not that it's bad or good, but mild cognitive impairment is we are exhibiting or seeing that this patient is having some issues with mental function or memory, but it is not warranted enough or discerning enough to call it dementia. So when we see this MCI diagnosis, What happens with our families is they say, oh, my mom doesn't have dementia, she has MCI. I had an OT daughter one time say that to me. And when I give you guys examples, it's not necessarily here, it's throughout my career to avoid conflict of interest. But this daughter that has an OT, background and works with dementia clients at the hospital was a bit in denial. She was thinking that things were going to be fine because her mom only had MCI. We do see with MCI, so like I said, there's this perception then that it isn't going to end up being any dementia. And maybe it won't be, but a lot of times, what we see is early MCI or mild cognitive impairment, which leads into dementia. This is a diagnosis that isn't severe enough. And like I said, it's in bold. The families are reluctant to intervene because it's not dementia. You can go to the next slide. You can turn to the next slide, or am I having internet issues?
There's some internet issues, Jean. I did turn to the next slide and you're delayed a little bit.
There we are. Okay. So warning signs of dementia, memory loss affecting daily life.
Jean, we've
Okay.
lost you again a little bit. Are you there? Jean, do you want to call in instead? Jean, this is Erin. We can't hear you. Would you like to hang up and call in?
Are you guys hearing me again?
Not for the last couple minutes.
Okay,
If everybody could hang tight, Jean is having some connection problems where she is, so she's probably calling in. Thank you for your patience.
I have called in. You just need to unmute me on the phone. That's probably better. Are you guys able to hear me?
Yes, with a little echo.
Okay. If you guys want to allow.
Sorry, Jean, we're still having trouble.
Come in on the phone.
If you're also on your computer, you have to shut that down. Like you can't have both, otherwise it's going to echo.
So I'm on the phone and I just joined back on Zoom. Were you guys able to hear me on the phone?
We can hear you now.
Okay.
Thank you for
So
your.
I did try calling in, but it would be better if somebody could let me enter on the phone and talk, because I know you have everybody on mute. Would that be a possibility?
I'm sorry, what do you need me to do?
I'm on the phone, so if you let me in on the phone and unmute me, then I can just keep going on the phone, because I'm probably going to continue to have internet issues. So
Okay.
unmute my phone, which is everybody will have my cell phone now, which is fine.
We can hear you.
20908.
Dean, we can hear you.
I know. Okay, I'll keep going then. I'm gonna leave the phone on just in case. You
Yep.
could go to the next slide. We talked a little bit about warning signs. So what is denial? Denial is cynical, calculated, and transparent. It's the first and foremost coping mechanism rooted deep in the human psyche, tapping into primal survival instincts, attempting to reassure feelings of normalcy. So what does all that mean? It means none of us want to know, whether you're the client or the family member, that somebody has dementia. They're in denial because it's a protective mechanism. That's really what that is. You can go to the next slide. So Americans in denial. This is something we are all good at as Americans. So when we're a clinician and we're seeing a family member or a client that is in denial about having mild cognitive impairment or dementia, remember that we all do this. We do it with our weight, right? Oh, I only weigh this much. Oh, I weigh less if I get on the scale without clothes on. I'm, 4 pounds lighter, and I'll start working out tomorrow. We see that people deny their age all the time. I don't see a lot of people embracing their age that are, 40 something and up. Romance, marriage issues, drugs, alcohol, exercise. So we all have some form of denial probably going on within our own personal life. So we've got to be patient with our families. You can go to the next slide. The sympathetic response. So there's the parasympathetic and the sympathetic response. And when we're full of anxiety, which we usually do not get to see our patients plan for them, we see them in a crisis, right? So they're full of anxiety. So they're dealing with the sympathetic response where they're freezing and they have flight and fight. They're not hearing anything you're saying. So all the time, I'm sure Brett can attest to this from the skilled home care area. And then all of you from hospice and from Bright Star, Leonard, from home care and Belmont Village, families, you talk to them about something, they didn't hear it. Remember, with your fellow peers and clinicians, we probably have gone over a lot of things with the family. But if you're having that issue, it's because they probably were full of anxiety and really were not able to comprehend what you were saying. You can go to the next slide. So emotional signs of chronic stress. This is when we see our families that they've been working with their loved one that has dementia for many years. And this means that they have been on a fight or flight forever, where now it's just the stress mechanism taken over. And now it's leading to further issues, depression, anxiety, irritability, concentration issues, even for the loved one that doesn't have dementia, compulsive behaviors. So remember, you're dealing with someone who probably is on caregiver burnout. And then you're grieving. So the Kubler-Ross stages of grieving, you could have a client that never remembered they had dementia because the doctor diagnosed them, and now this is a couple of years later and they're hearing it again. So they can go through each of these stages in that next hour, denial, being angry about it. I don't want dementia. What are you talking about? To bargaining, to depression. And this happens for our families too, because they're dealing with their loved one that has this and they don't want to think of their loved one having that. And a perfect example I have is we had a client that had dementia, had been diagnosed, forgot she had it, and was with the family who went to the doctor and she got the diagnosis. She tried to throw herself in front of a car. And actually our nurse brought her into the ER. We tried call 911, suicidal ideation, definitely she was suicidal. And they did not want to take her into the hospital. So we drove her into the hospital into psych, which she needed anyway. She was having some combative issues. You can go to the next slide. So what's the family impact on dementia? The The nuclear family has a whole emotional process. We're going to go through that. We're going to talk about siblings. The family projection, they may be projecting their own thoughts or ideas onto the loved one or back and forth. Multi-generational transmission means, sometimes in families, you'll see the same patterns over and over. And a basic example will be, every generation had a child out of wedlock. Every generation has addiction issues, which also is genetic, of course. So you're going to see some processing from the family that is something that is learned patterns. Sibling position we'll talk about, and some people emotionally cut off, especially if they're not part of the family unit. They've already distanced themselves because of dysfunctionality within the family. And I will tell you, in my 20 some years of nursing, I've probably met 4 families that were fairly functional. The rest of them and the rest of us probably have some dysfunction in our family. The person that says, and I remember being in discharge rounds when I was in the hospital, the person or the family member that's not involved, and maybe they are the power of attorney, the discharge planner and the home care liaison, I was a home care liaison back then, the physical therapist, et cetera, would be in rounds and people would say, well, I don't understand why the daughter isn't stepping up. Well, the daughter stopped stepping up 20 years ago, maybe, with dysfunctional impact from alcoholism or whatever the issues were. It's actually sometimes a healthy thing for the family member to step away. You can go on to the next slide. Reasons for denial. Coping, they have poor coping mechanisms. What do we do when a lot of us who are in healthcare, we like to compartmentalize issues. That means I might have just seen a client that was on their deathbed and we're dealing with hospice for our client and we're trying to be with our client and do the right things. So our hospice provider on here can definitely attest to that. But now you have to go to the next client and you're doing palliative care with them and they're doing well. So you've got to just kind of put those thoughts aside. The client might not remember getting the diagnosis. We talked about that. There is a big misconception about aging. We talked about that. There's a stigma, of course, about having dementia. I mean, people joke about it all the time in their 30s and 40s when they start having a little bit of word retrieval. A lot of times the patient is going in and out of lucidity. So they're doing well, then they're not doing well. And the family thinks, well, they're having a good day, so they must be okay. Long distance family members, if you are in any of our care provider settings, you are getting that call from, example, a daughter in New York. My mom was fine a week ago before the hospitalization. Well, that was before she had the UTI, and she probably didn't share with you that she had dementia for the last 3 years, and she's got other health history. So now she is, struggling, and the family member will just stick to that. I saw my mom 2 weeks ago. I was in town. She was doing fine. Well, things can change quickly. Some of the things that we need to talk about is have compassion with our families and say, this could change. These are the things that she's doing right now. And you want to give some really serious examples. Maybe the patient is hitting people. Maybe she's saying, I just want my baby because she's regressing. You want to tell the family those things. It's not being mean. It's getting them to understand that this is really happening and try to help with some of the denial. You can go to the next slide. So what are some of the risks of denial? Well, first of all, the time we see all these patients with dementia is in crisis. So they're not going to get the medical intervention they need. And it is a very expensive diagnosis if it's not handled the right way in the beginning. Getting their powers of attorney, making sure that they have the right diagnosis. They've done a neuropsych eval to find out where they're at in their diagnosis. Just getting that medical intervention, maybe getting some of the medications that help stave off further dementia, like Aricept. There's family conflict over diagnosis. So sometimes they know that the daughter or son is not going to be able to handle hearing that diagnosis. So the family keeps it to themselves. And I can think of an example just from a friend recently. It wasn't dementia, but it was the C word, it was cancer. And they never told the daughter and son how far and how progressed the diagnosis of cancer was. It was all over her body at this point. And they were refusing to do hospice. They wanted palliative. Well, the mother and father were trying to protect the kids, but then they had to do all grieving at the last minute as she was dying. Financial exploitation is a huge issue with clients with dementia. So if we're not getting them the help they need early, or if we're not reporting families to APS, Adult Protective Services, early when they're having issues that we think maybe somebody is taking money from the bank account. We're doing a disservice to our patients. You can go to the next slide. So healthcare clinician bias. We have the training, we have the knowledge, right? So we think, why are they not getting on board? Why don't they understand that their mom or dad has dementia? It's because we have years of training in this. We see it all the time. If you work with dementia a lot, I don't even need to do a mini mental exam. I can see it fairly quickly just by asking a few simple questions. But that's because we have that background. We tend to look at things through a clinical lens. And let's face it, our bias is we don't have time. So most of the providers on here, you got 15 or 20 minutes to spend with a client, maybe an hour, and you've got to move on to your next patient, your next client. And we just want them to get it and understand. This takes many, many conversations. We're not family, so of course we're not emotional, right? We're objective about it. Just be patient with the family. Try to get many healthcare providers saying the same thing to the family. In other words, if we're all on the same page and telling them the same things, the more that they're going to accept and understand that. Sometimes we have the primary caregiver, like the spouse, is covering up the dementia for the family. So nobody even knows there's a diagnosis of dementia. I can't tell you how many times I've gone into a chart and a family member is telling me this is brand new from the hospital. No, they were diagnosed 10 years ago. Now, of course, you got to be careful when you share that. You got to make sure you're talking to the POA or you have the okay from the family to talk to the kids. So you want to make sure you're practicing and looking at HIPAA so you're not violating that. But there's always somebody that's trying to make things better for the person struggling. And it's really easy for that spouse to cover up for an hour when the kids come to visit, and it makes it look like they're doing well. So again, we only have a really short time with our families. And a lot of times the families, when that client's doing well, moments of clarity, they say, well, they don't need anything now. They were in the hospital and now a week later, they're doing well, they're back to driving, but they're still alert and oriented times 2. And they still are struggling with word retrieval. And we do know that dementia is progressive, but the family gets confused when they start doing a little bit better. And guess what? That's when they stop home care. That's when they stop palliative care. It's when they stop hospice if it's warranted. And that's when they think they don't need to move into a community. And you want to move into a community like Belmont when you're actually doing a little bit better. So the adjust there, right? When their dementia is early with all the different levels of dementia care there. Go to the next slide. So clinician tips. If you are with the client, a mini mental exam is a really easy thing to do, the MMSC. I don't use the MOCA, the MOCA. You actually have to pay for the license to use it. But the MMSC is really easy to use. If you're not familiar with it, I can always email that to you. But what I find a lot is with my clients, even that aren't decisional, that are really, really, really intelligent. And that's a few lines further down bullet points. But the intelligent clients can spend a lot of mental energy for an hour covering up their illness, covering up their dementia, and they are crafty at using the right words and expressions to use so that you don't see that there's issues. I've actually had nurses assess clients with dementia, and I know the client is not decisional and power of attorney is in effect, and the nurse may miss it, or whoever's assessing that client, not necessarily a nurse, social worker, whatnot. So if you're really not sure after an MMSC and they score fairly high, you may want to use a neuropsychological evaluation. So find a neuropsych doctor. They can come into the hospital, to the rehab, or in the home setting, or even telemedicine. You want to make sure you're very careful, if you are a provider, getting consents for these clients. I cannot tell you how many times a client has had a guardian or a power of attorney and the consent was received from the client. So make sure they are decisional, and you otherwise look to see who is that power of attorney. And there's a difference between springing immediate power of attorney, which is a whole nother subject, but you can go into the chart and you can ask the client, can I talk to your daughter who's power of attorney? So if you're not, like I said, if you're not sure who's handling things and you're getting a feeling that they're not decisional, but you don't have documentation that they're not, you can just ask you could speak to the power of attorney. You can go ahead to the next slide. And you can skip these slides, the next few, for the sake of time. So stigma of medical profession. Here's the issue that we all encounter, every single one of us on the call. There's 104 of us on here. We end up working with families that have already been turned and churned and burned by the medical system. That has nothing with us on this call. It has to do with the way things are set up. Insurance and prior auths and various doctors and multiple hospitalizations and all the different providers that come in and out of the room on a daily basis to get info from the client, from the chart to do their job better, right? So families sometimes don't trust the healthcare providers. I encounter this a lot because by the time that they get to us to help them with everything, they're just exhausted and they've gone on the internet. Average family spends about 15 hours a week researching information when we all have it and know it and can help those families. And what we're seeing is there's decades long of decline in trust in medical professionals. So right now in 2014, it's a little bit old, the data, only 23% basically trusted medical professionals. So that we're just seeing that the trust factor is going lower. And you can skip to the next slide. So some of the things that the families are not trusting about healthcare professionals, they feel like profits ahead of patients. So maybe the big organizations, they feel, this is the families, feel like that maybe they're putting profit ahead of everything. They feel like there's a lack of disclosing conflicts of interest. So possibly at the hospital, there's a home care company that the hospital might be saying, this is a home care company that we work with or is in line with us, but the family wants to use another one or a hospice company or whatnot, or at a rehab. It doesn't have to be at a hospital. So they feel like when something's getting pushed more, they're wondering about the conflict of interest. Difficulty accessing medical records. A lot of times families can't get these till the patient leaves. And then there's questions on a lot of things. Because what's happening is the last couple of days before discharge is usually when we're getting the answers, right? Average length of stay at a hospital is 3 days. But like the last 1 or 2 days is when we're got the test results and we're able to talk to the client about what their diagnoses are and what the treatments are. So all that is coming very quickly. And then the family is getting all this information. Sometimes even the last minute we're getting tests in. If it's a neuropsych eval, it takes a while to write that up. And the client and the family are waiting to hear, is it dementia or not? Conflicting medical guidance from healthcare professionals. This just happens when you've got multiple docs on a case. It's great because they're a specialty in their area, but they may be giving conflicting advice. And you could go to the next slide. I'm going to skip over this slide. I'm just going to say that siblings, there is nothing but distress among talking to the client's family, because all of those sibling animosities come to the forefront. So their roles. Who was the scapegoat? Who's the favorite child? Who's the child that probably left? The family was dysfunctional and they got out of there. So the sibling issues are big. You have to spend a lot of time with the family members, and it's better to have them on one call together, because if you have manipulative family members or families that don't understand, they start spreading the operator game of the wrong info. You can go ahead to the next slide. Spousal stressors, they've gotten used to this client being this way every day. So it's hard for them to see the decline because they see him every day. It's just like when you're trying to lose weight and your spouse sees you every day, they can't really see it coming off of you. But a friend who hasn't seen you for a couple of weeks can see that. And then I wanted to touch upon our different types of providers that are on here. You can go ahead and go to the end, and then I'll open it up for questions because I know it's 1:43. I'll leave this up here about caregiver burnout too. We talked a little bit about that earlier with our family members. One thing I do want to say about caregiver burnout before I go into the providers is when you see a daughter who's screaming and yelling and angry, they're probably a nice person, but if they've been dealing with this with their mom for 10 years and they've been the primary caregiver, they're exhausted. Take them somewhere, let them sit down, give them a shoulder to cry on. just quiet and listen. I always tell my my family members who can't listen to mom or dad or staff, like, just put yourself on mute if you have to on the phone. Give them time to process. They usually will calm down. So a little bit about our providers. When you're working and you're trying to refer out from a rehab or hospital setting or an assisted living or wherever you work, try to remember all the resources that are at your fingertips. There's 103 of us on this call. So you've got skilled is always a resource for physical therapy. If they have a skilled need, they don't necessarily need to be at a hospital, but there has to be a diagnosis that's driving the skilled need for the home care, skilled home care. Medicare covers that, right? So when you get your physical therapy and your nurse out to assess the client, you can have that nurse showing the family member, if I know you don't believe that your mom is having difficulty and that the dementia is affecting her, but I did let her try to set up her own meds last week and she struggled. Can I have you watch this? The daughter will say yes. You don't want to say that in front of the client, of course. You want to have this conversation with the daughter away from the client. Let the client try and set up the meds. They're not going to be able to do that. But always bring in your social worker. So at the hospital level, if you're ordering skilled home care for home, order social work if you see dementia, because there's a lot of factors to this diagnosis. Financial abuse, family stressors, driving, where are they at in their diagnosis, other comorbidities, et cetera. And then the non-skilled home care or caregiver, you want to make sure that you're bringing in a caregiver early, especially if the family member is exhibiting caregiver burnout symptoms. They need someone to come in a respite stay and do some cooking, cleaning, bathing, and sitting with that client so that their loved one can go out shopping. And when this disease progresses and the family thinks they can be home alone, you guys have all seen this, it's 24/7 care. So this is when we want to bring in the caregiver, the home care companies, like Bright Star. And then hospice. So with hospice and palliative care, sometimes, the client or the family, someone is not going to be ready almost all the time. You can bring in palliative to start. It's not the best when they need hospice, but it's an introduction to the services so you can transition them to hospice quickly. And I see some features on the chat. So I'll look at the chat in a minute here so I can look at all of that. And then with our communities like Belmont on here, there is a lot of paperwork to do. Doctors want to fill out the paperwork to get the clients in these communities, but usually it takes 3 or 4 times of prompting the doc to do it. Because why? They have high acuity patients. We've got COVID going on right now. Patients are in and out. They don't have a lot of time to sit down and do paperwork. So it takes time to get that paperwork back. We also need to make sure if they're moving into a community that they have a chest x-ray done to rule out tuberculosis or a MAN2 test. We also need to get a nurse out there to do an assessment. We also need to make sure that the client is comfortable with the community. And the bigger thing is, which is easy for communities to work on, is they need to figure out what language are they going to use with the client and the family to get them into the community for them to be calm. Because that's a big transition that day they move in, especially if the client really is not as 100% comfortable moving in. And they always do a fantastic job and make sure that the client is, doing fine and in the activities and, getting walked down to the dining room and different things that day. And they transition very easily. So I think I touched on each of the different types of care providers, and I'm going to go ahead and leave it open for questions, and I'm going to look at the chat feature here. You can read those.
I see, Jean, I see one.
I'm trying to pull up the chat right now.
I see one right now. Do you want me to read it to you, Jean?
There we go. So I apologize if you guys had trouble with hearing. Yeah.
Jean, it's Erin. Do you want me to read you this situation in the chat?
Yeah, could you? That would be great. I'm going to leave my video off and it's better for the internet.
Yes, yeah. It says, I have a client who was recently diagnosed with mild cognitive impairment. The family wants the client to move to a supportive living or nursing home facility, and the client refuses to do so. I suggested that the family ask client to stay in facility for a few weeks to see if they like it, but client refuses to do this. How can the family convince the client to move into the facility?
So this is where you need the help of a professional. And that could be like Erin, somebody at Belmont Village, say it was Belmont Village, or at the supportive living. So you want to have one of those professionals working with you, and they're experts at working with the family to talk to them about that. You can also bring in a private care manager from any company. It doesn't have to be us. It could be any company, because it takes time for each of the family members, the spouse and the client to consider this. Supportive living, just so you know, just a little sidebar, is appropriate, but it cannot be a primary diagnosis of dementia. So if the client has a very, very mild dementia, it could be appropriate for a little bit, but they're probably going to need to move them into a memory care at some point. And dementia is always try to get them into one community so that they can stay there and age in place, because that confuses them more with dementia when you move them. Some other tips are, making sure that these are some things that therapeutic lies, I know we do them. If the dementia is pretty progressed, you want to talk to the client and say, we're going to go out to lunch today, and we're going to go in and eat lunch at this nice place. And it might be at the community. And at the community, the staff will be there and know what's going on because the family's communicated with them. And the community people can bring the lunch to them, but then also can talk about touring them into the building. And then maybe you already have it set up where they're staying there at this point. And Erin, if you could speak to that a little bit, I don't know if you do that. Sometimes I've seen that with some clients that are really difficult.
Jean, I'm sorry, can you repeat the question? I just got a text from somebody and I was responding. Could you repeat it again, please?
No problem. I was saying that sometimes we use some information with the client, like we're going to go to lunch. We're going out to lunch today, but we're really moving them into the community and they're too combative or too, they don't want to go. There's just no way to get them there. There's sometimes where we have to do that with a client, and then the staff is there to tour them, to bring lunch to them, and to transition them into the community. I have done that with clients before with communities. I just wanted to know if you wanted to speak to that.
You want me to speak to whether we would accept someone with behaviors with dementia? Is that what you're asking?
No, if actually you're telling the client you're going out to lunch at a restaurant, but you're really bringing them into the community to stay because they've been too resistant the whole time.
Oh, I see. I understand. You know what? I couldn't speak to that part as much as our director of memory care. I know we've had to do some sort of creative things with our clients and the families to get them in. So yes, we will work with the families and any care managers that are involved to make it an easier transition for sure. Yes.
Okay, great. That's perfect. Let's see if I see anything else. Does Medicaid cover memory care service for long-term? So at the long-term care communities that have various levels of care with memory care, there are a few supportive living communities that do have memory care, locked memory care on site. There's only a few in Illinois. And in Wisconsin, not that anyone, I don't know, we have 100 and some people, so somebody might live closer to Wisconsin. Clients can stay in memory care under Medicaid in a assisted living type memory care. And then there are some communities that will accept Medicaid waivers, and they will work with Medicaid if the client has bought into the community, like a CCRC, which is a continuing, I always forget what exactly it stands for, but continuing retirement community. So they can stay sometimes, but you need to ask that ahead of time. And you need to get that in writing that they will keep the patient on Medicaid. There is so much to learn on levels of care. I've always wanted to do a presentation on it, the 7 or 8 different levels, and what is covered, what's not covered, because it's very confusing.
Jean,
And then there's
did you see
sure,
the
go
other
ahead.
question about a tip? Somebody wanted a tip for getting an outpatient neuropsych eval for a patient when that patient is resistant to show up for an appointment.
That's another time if the client, their dementia is fairly progressed. I mean, think about dementia and how scary it is for the client. They don't know what a lamp is, what a bed is, what a computer is. And now people are talking to them. They don't remember if there's someone they know. It depends on where they're at with their dementia. So it could be that, right, that it's progressed, or it could be denial and the client doesn't want to do this. So you can't really do this, but you could talk with, if the family member's bringing them, you could say to the family member, tell them you're going to a doctor visit, and that doctor, the regular doctor, is just going to check them out for any kind of medical issues. I wouldn't go, when they start asking the memory questions, the daughter can say to the client, you always want to keep things simple with dementia clients. I always remind daughters to do that, is the doctor needs to ask you some of these questions to figure things out. So that's my tip, and it works almost every time. I know we're not giving the 100% truth to the client, but they're not able to understand the truth sometimes. Obviously, if it's very early dementia, you don't want to do that. You want to just say, don't you want to know? And if they say, well, I don't have dementia and it's not bad, that's exactly why we're going for the appointment, so they can prove that you don't have dementia and it's not bad. That's another tip you can use. I use all kinds of things. Somebody says I always use the insurance adjuster. I think you mean like, this is something we need to do, Julianne, for insurance, that the insurance company wants it done. I am not sure if that's what you mean. And you can respond to that in chat if you want. Julianne says it's a trick you use. There's a lot of them you can use. Just always keep it simple. Tell the family to keep it simple. And like I said, you can tell them, you can use it the other way, that you're going to this appointment. The clients that are over like 75 love their primary doctor. The primary doctor wants you to do this. That's another one I use all the time. The primary doctor wants you to show how well you're doing, so your daughter understands that. Of course, you tell the daughter that this is what you're saying to the client, so the daughter doesn't think, well, what do you mean? I mean, I know she has dementia. She needs help. You just make it about, we're just trying to prove this to your daughter, you're doing well.
I think that's all the questions I see in chat, Jean. If anyone has any last minute questions for Jean, or any of us actually, please put them in the chat now before we complete the program. Okay. Jean, are we going to get a copy of the slideshow? Jean, that's up to you whether we can send that out or not.
Sure. Yeah, that's fine.
Okay, thank you.
I see
All right.
one more.
What's that?
Oh, I just see one more comment. It's a couple more.
Please go ahead.
Another question. Should I answer that?
Yes, of course.
I'm going to turn off my video, you guys, only because my ridiculous internet. So that I don't get all bumpy when I'm talking. How do you deal with family who are so upset when client does not remember them? You know, what I tell families is whatever the client had in memory right now, let's say you're 75, they are going like now I'm aging myself, I'm 50, right? So a tape recorder, it's going backwards in time. So when you're rewinding that tape recorder, they're starting to lose memory function from this day going backwards. And that goes all the way from not remembering 2 months ago going to Florida, not remembering 2 years ago when the grandchild was born, right? Their favorite daughter with the grandchild, going back 10 more, 15, 20 more years, whatever, that the youngest daughter was born. But they still remember the oldest daughter. So it's really just like a backwards tape recorder that they're erasing time. And there's a movie that I'm thinking of right now off the top of my head with Jim Carrey, where he tries to erase his memory about, like, you know, dating this person. And it's kind of what's happening to our dementia clients. Can patients get respite care on Medicaid? Respite care with a caregiver at home, they can get under VA, veterans benefits. Medicaid, that's a tricky one. So the family can be, and I can let Leonard speak to that if he wants to. I know that a family member can actually work with Medicaid and get paid to take care of the client. And Leonard, do you want to speak to that? That's the only way. Respite care can be done, just so you guys know, with caregivers in the home or like at a community like a Belmont Village, and that would be private pay there. And Medicaid, the only option I can think of, like I said, is if the family member. Go ahead, Leonard.
Yeah,
Take it away.
in these cases, sometimes you try to encourage the family for, even if it's just 1 hour service or a couple hour service, we can do that on a private pay. So Bright Star will work with the families best they can. A lot of times we also bump into those who, well, I don't want any care, regardless, in home or outside the home. So at that point, we run in situations where we just encourage the family to see if they can get a hold of someone that the patient or the resident does respect, to get that sort of respite care, because a story needs to be told, obviously, that the adult children need some assistance themselves. And of course, that could be a godsend if they just have an hour, 2 hours, or a few hours to themselves. But they're mostly also concerned for the safe and well-being of their loved one. So don't know if I was able to answer the question about that. I know we've gotten involved with county services to intervene, ombudsman to help facilitate or mediate the situation. Does that help?
Yeah, that was excellent. You know, another option too for respite care is working with the church. Sometimes they have volunteers.
Yep.
That can come out if they can't afford caregiver services. But even if they, you know, do 2 or 3 hours, you know,
Right.
for the family member to get out, you know, and it's, let's say $28, $29 an hour, $30 an hour, that can be worth it. And always, a lot of times clients do not remember that they purchased long-term care policies. I can't tell you how many times I've been in a house and we're like, if we're more involved, right? So, and I'm giving you an example of any care manager out there, not just me, but you're in there and you are trying to figure out what's going on because this client has been hiding from their family, trying to cover up their dementia for years. And all of a sudden the mail's coming in and the family wants you to look at the mail because they live long distance. And you see Genworth coming in, or CNA, or John Hancock. Those are all long-term care policies that the family has no idea that their loved one purchased when they were working, because you want to buy those policies when you're younger, like 40.
Yeah.
And then somebody has a comment about, oh, go ahead, Leonard. Yeah.
I'm sorry. Also, we're finding out on an upswing that people don't realize that they have the benefits if they're a veteran, or their spouses do too. When you finally find out that he did serve the country, or she did, or is a spouse of someone who did. So they need to talk to their social services representative at the VA, but we find out more times than not that they didn't realize those benefits existed.
Absolutely. Yeah, I did talk about the veterans benefits, and you can connect the client with that. And then there are some hours for, and if the caregiver company is connected with the VA, they can provide service. And then somebody did say in regards to the respite with Medicaid, oh no, they were talking about the caregivers with Medicaid. The client has to be at a certain asset level to qualify for a family member to be a paid caregiver. Absolutely. Lots of hoops you have to jump through for Medicaid and spend down to Medicaid. And that's a whole nother presentation we can do, how to do that and what that looks like and what services are out there. Because that's always our question mark, right? We always want to give the best care to our clients, and they might not be able to afford some of the things out there. And so Medicaid's always a big question. And I know if it's not respite care, but they need physical therapy, nursing, Medicaid can cover that at home with a skilled home care provider, but there has to be an end date in sight, and the patient is, it's going to be on service maybe a few weeks, but it is helpful to get the ball rolling and get that social worker in, physical therapist in, and a nurse. So I'm going to go ahead and say thank you so much to all the sponsors for letting me be here. I'm so sorry about the internet, and just thank you.
Jean, thank you very much. And you handled the internet technology thing like a pro without panicking. So thank you. We really enjoyed your presentation. Thank you to everybody for joining us. Thank you also to our, to Belmont Village, Bright Star, CareLink Home Health, and Suncrest Hospice for your sponsorship and participation. We will send out a recording to everybody sometime later today, so you will have that. And I also want to remind you, for those of you who have signed up to pick up a Valentine's treat basket at Belmont Village today, you are able to do so from 4 to 6 p.m. as long as you indicated that on the registration form. So we will be waiting to meet you and excited to meet you. So thanks again, everyone, for your participation, and have a wonderful day. Thanks.